Greetings from National Academy of Medical Sciences, India. NAMS has been recognized by the Government of India as a nodal agency for promoting the continuing medical education for medical and allied health professionals. National Academy of Medical Sciences encourages and sponsors nationwide CME programs, symposia and workshops in basic sciences and applied clinical disciplines. In the virtual meeting held on 13 December 2022, more than 200 directors, deans, principals, CEOs, faculty members of the medical colleges and medical institutes decided unanimously that there is a need for the NAMS National Virtual Graduated Medical CME, Navigate Medico CME, program for PG students, MD, MS, DNB, MDS. Accordingly, the Navigate Medico CME program was launched on 22 January 2023 by the NAMS President, Professor Dr. S.K. Sareen. Each online session is of 2 hours covering practical aspects as per the needs of the PG students in the identified theme areas. Thank you for your kind support.
Hello and good evening, everyone. So, welcome to the next session and today's session of online Navigate Medico CME program by the National Academy of Medical Sciences. So, in the order to start the program, I would like to invite Professor Umesh Kapil, Secretary of National Academy of Medical Sciences, for the welcome address. Sir, please.
Thank you very much, Dr. Jaswant, for a kind invite. On behalf of National Academy of Medical Sciences, I welcome all the participants, all the invited speakers, and especially Dr. Ella Varsi from Indian Institute of Medical Sciences, my alma mater. I am the place. I served there for almost 45 years. And now I have joined National Academy of Medical Sciences. I know it's a very vibrant place. It's academically very vibrant place. And the faculty over there are always outside. They are the best. I'll just give you a brief about the Navigate program. This National Virtual Graduate Medical Education Program, that's Navigate in brief, essentially we started a humble effort to provide the state-of-art knowledge to the postgraduates as well as those who want to go into the NEET examination and clear it. If you look at the country, we have about 100,000 population MBBS doctors who pass out. About 6 to 8,000 get into the MD/MS in the medical colleges of government and the private sector. About another 6 to 8,000 get into the DNB program. So about 84,000 doctors, MBBS, they want to do their post-graduation, but do not get the opportunity because of certain reasons, like they are unable to clear the NEET examination. So NAMS in its wisdom made a humble effort that we try to go through the online mode and try to provide them the best of the best presentations by most eminent people in the country. We requested Dr. Padma, head of the Department of Neurology, to help us out in this venture. And Dr. Padma had accepted our request, and about 4 lectures and presentations were agreed upon, and this is the 4th one in the series. Now, all these lectures would be available online at our NAMS website in virtual mode. All the corporate presentation would be available from the uh, from the NAMS website, and we hope that the doctors, the postgraduates, would take care of these advantage of this NAMS website presentation which is being done. With these few words, I would like to say that we are most grateful to you, Dr. Ella Varsiji, and Dr. Padma also, who have very kindly agreed, and also to our dear colleagues, Dr. Jaswant and Dr. P.K. from Department of Psychiatry and All India Institute of Medical Sciences, who very kindly agreed to help us in this venture. With these few comments, thank you very much. Welcome all of you again. Thank you very much. Over to you, Dr. Jaswant. Thank you very much.
Thank you, sir. Thank you, sir. So now coming to the today's topic, that is very, very important and one of the most common presentation in the OPD, whether it be the neurology OPD, medicine OPD, psychiatry OPD, or even a OPD of any general physician. The topic is very important and very common, that is headache. So ma'am is like going to present this very, very important topic, and I'm sure that ma'am is going to do justice with this topic. So I would like to introduce ma'am. I know ma'am personally, and she is very, very hardworking. I've worked with ma'am. Ma'am is currently assistant professor in the Department of Neurology at AIMS New Delhi. She has special areas of interest, mainly in botulinum toxin and uses neuroimmunology, movement disorders, stroke, evidence-based medicine, and clinical neurology. She has a numerous award in her name. She has MDS travel grant for movement disorder society conference Madrid 2022. She has been awarded with fellowship of World Federation of Neurology Junior Traveling Fellowship in 2019, American Academy of Neurology International Scholarship in 2018, MDS Travel Bursary of Basic Sciences Summer School, Osaka 2018, MDS Travel Grant for Movement Disorder Society Conference Hong Kong 2018, award paper in IAN Con 2018, winner of MDSI Con 2017 quiz competition, winner of DNA Con 2017 competition, award paper in DNA Con 2016, and she has many papers and many papers in the very reputed journals of our scientific society. So I again welcome ma'am, Dr. Ila Varsi. So now she is going to present a very, very important topic of headache. So welcome ma'am, and over to you ma'am, please.
Thank you. Thank you, Dr. Jaswant, for that kind introduction, and Dr. Kapil for giving me this opportunity. I would, at the outset, thank the National Academy of Medical Sciences for this very good initiative to ensure that there is continued medical education to our graduates of our country, and who are actually providing excellent healthcare to the nook and cranny and all the different strata of the society. So without much ado, let us just move into the topic. I will start sharing my screen. The technical team, can you just tell me if the screen is visible?
It's visible, ma'am.
Okay. So let us start the presentation. So headache is one of the most common human ailments, and 3 billion people worldwide suffer from headache disorders. So we should note that the population of the entire world is somewhere around 8 billion, and 3 billion are suffering from some or the other form of headache disorders. It is the commonest problem which is evaluated by neurologists, and headache, as we know, is caused due to any involvement of the pain sensitive structures of the head and neck. For the layperson, whenever they start having headaches, the most common fear is, am I suffering from a brain tumor? So, but as physicians, we should remember that brain is not pain sensitive. The pain-sensitive structures of the head and neck are the extracranial tissues, such as the scalp, extracranial soft tissues, blood vessels, the carotids, extracranial head and neck vessels, and the temporal arteries. In the intracranial structure, the dural venous sinuses, large arteries of the circle of Willis, and pial arteries are pain sensitive. Rest of the intracranial structures are pain insensitive. Coming to the neck structures, the bones, soft tissue, muscle, fascia, lymph nodes, ear, nose, and throat structures, teeth, gums, buccal mucosa, involvement of any of these structures can present in a patient with headache. So headache doesn't mean always neurological. And as Dr. Jaswant rightly said, every physician, whether it is the ENT specialist, whether it is the dental surgeon, whether it is the psychiatrist, all of us are facing patients with headaches. So we should know how to approach such a patient. So when we approach from the neurologic perspective, the first step is to find out whether it is a primary headache or a secondary headache. So what do we mean when we say someone has a primary headache? Primary headache means that those who do not have a secondary cause. Secondary causes or causes like trauma, infection, intracranial lesion, vascular lesion, raised intracranial pressure, or pathology of any of the structures of the head and neck, as we discussed in the previous slide. So this distinction is essential to classify the disease and to evaluate. Primary headaches may also be associated with other secondary conditions. So we need to find out why it is important. Because as we saw earlier, 3 billion people in the world suffer from headache disorders. So by magnitude, primary headache disorders are much more common as compared to secondary headaches. So as you see, we saw 3 billion people are suffering from headaches and 1.89 billion, nearly 2 billion are suffering from tension type headaches and 1 billion is suffering from migraine. So secondary headaches are very, very rare, and identifying a secondary headache is like identifying a needle in a haystack. So whenever some patient comes to me and says they are suffering from headache, what do? There can be two methods. One is I start screening every blade of hair. Whenever I see some patient, I do MRI and MR venography of each patient. I get the fundus examination and I do lumbar puncture and measure the CSF pressure, do CSF manometry in all patients. Now, is that a smart way to work? I don't think so. So we will do the second method in which we will work smart. We will use a magnet to pick up the ferromagnetic substances and then screen them to see if there are needles. So what are the magnets that we use to identify secondary causes? So first and foremost, we ask the frequency of headache in that particular patient, and is there a change in the frequency, duration, or the characteristics of the headaches? Does the patient suffer from fever or has other constitutional symptoms? Are there any bruise over the scalp? Is the patient pregnant or on any oral contraceptive pills? Does the patient have known malignancy? Is there progressive increase in the severity of the headaches? Is the patient having other neurological deficits like ophthalmoplegia, ptosis, cranial nerve palsy, long tract signs? Does the patient also have associated seizures? Are there any red flags, new deficits, transient visual obscurations, pulsatile tinnitus? So these are all various findings which help us to point us towards some secondary cause of headache, and we can use it to pick patients who will have the maximum yield from further evaluation. So this might seem like a very long and a tedious list. Let me simplify it for you. And we use the SNOOP mnemonic. So SNOOP we have 5 letters in the word SNOOP. So the first S stands for systemic symptoms. Does the patient have fever, night sweats, chills, weight loss, jaw claudication? N stands for neurologic symptoms or signs. Does the patient have confusion, any focal neurologic deficits, diplopia, transient obscurations, pulsatile tinnitus? O stands for onset. Whether the onset is new onset headaches, did it start like a thunderclap headache? It was the worst headache of the patient's life. The next O stands for older age. Any new onset headache in a patient who is more than 50 years of age has to be viewed with a suspicion for secondary causes of headache. Then the next word, letter P, stands for 4 things. One, is there any positional variation with the headache? Two, is the patient having any past history of any significant illness like CKD or HIV, which suggests that the patient might be having a secondary cause of headache. P stands for pregnancy or postpartum. The last P stands for precipitated by Valsalva maneuver. So precipitation by Valsalva maneuver means that the patient might be having some cause of associated raised intracranial pressure. And so this Snoop mnemonic will help us identify the secondary causes. But when it comes to individual patient, how to use this, that we will see in some of the case vignettes that I will be discussing. So we have a list of 5 cases. All of them have almost the same type of clinical profile. And let us see what is different in each of these cases. The first patient is a 25-year-old female who is a software professional. She comes and tells in the OPD that she has been having recurrent headaches since the last 10 years. Most of the times it is right hemicranial and occasionally it is left-sided also. She says she is having headaches every alternate day, which is 3 to 4 times per week. And each episode lasts for 4 to 6 hours. She said it was moderate in intensity, occasionally associated with vomiting, but most of the time she has nausea. It is associated with photophobia and phonophobia. And it is aggravated by traveling and delay in taking meals. And she says when she sleeps and wakes up, she feels refreshed and the headache is gone. So these is a prototype patient of a primary headache disorder. There are no red flags. The patient did not have any fever, loss of appetite, scalp tenderness, or systemic symptoms. So this is the classical patient who presents with migraine with aura. And this is how most of the patients with migraine present. They present with hemicranial headache, which is moderate to severe in intensity. It is aggravated by exposure to noise and lights like photophobia and phonophobia. And it may be associated with nausea and sometimes with vomiting. And these are the characteristic relieving factors like sleep. And sometimes patients take analgesics to relieve the pain. So let us move to the next case. This patient is also a case of 25-year-old lady who comes and says she has right-sided episodic headaches since the last 2 years. Now, what has to be understood is the previous patient was also having hemicranial headaches, but most of the times it was on the right side, but she also had some episodes of pain in the left hemicranium also. This second patient has only right-sided headaches. This side lock headache is something that we have to pay attention to. Then the second thing that the patient said was she is having pain which lasts for 30 minutes to 1 hour. And whenever she has the pain, it is associated with right-sided conjunctival redness, watering from one eye, right nasal block, and right-sided slight drooping of the eyelid. And all these symptoms resolve spontaneously, and she has multiple episodes, up to 10 episodes per day. So what does this patient have? So characteristically, this patient seems to have a unilateral headache associated with trigeminal autonomic symptoms. Trigeminal autonomic symptoms are restricted to the areas which are innervated by the trigeminal nerve unilaterally. So this is a characteristic case of trigeminal autonomic cephalalgia. There are no red flags. The patient has been having headaches since the last 2 years. There is no change in the character of the headache. And this patient clearly has a unilateral headache with associated trigeminal autonomic symptoms. So this is a classical case of paroxysmal hemicrania. So far we have seen 2 types of disorders which are prototype. The first was a patient with migraine, which is the commonest disorder which neurologists treat. And then we have the next category of primary headache disorders, which is tension type headaches, which is by and large the most common type of headache, which, as we saw before, affects almost 2 billion people in the world. And tension type headaches are seen by almost every physician, including the general physician, including the primary care physician, including the family physician, and even the psychiatrist. Then coming to the trigeminal autonomic cephalalgias, we have mainly 4 categories in that. One is cluster headache. 2 is the classical case of paroxysmal hemicrania that we saw. If the paroxysmal hemicrania patients have later on developed continuous headaches, or to begin with only they have continuous headaches, we call it hemicrania continua. And we have this specific entity called SUNA or SUNCT, which is also a form of trigeminal autonomic cephalalgia, which is very rare. And it also is associated with episodic headaches and trigeminal symptoms restricted to one half of the face or head. Then we have other primary headache disorders like primary cough headaches, primary exercise related headaches, primary headaches related to sexual activity, hypnic headaches, and annular headaches, which are also not associated with any other secondary causes as we had discussed before. So now let us move on to the third case. This is also a 25-year-old lady who has come with new onset severe headache since 6 hours. And this patient has vomited thrice in the last 6 hours. And she also said that she has right temporal pain, which was radiating to her right ear. And she also said she has blurring of vision in both eyes since the last 1 hour. And on examination, this patient immediately rushed to the emergency because she had this new onset headache and she was vomiting. So the resident examined the patient in the emergency and found to have bilateral papilledema. So point number one to remember is any patient who presents with such a new onset headache or even chronic headaches, the fundus should always be examined. Always be examined, because papilledema is such a sinister finding that suggests that we need to act immediately. So this patient was taken to the MRI suite and the patient underwent MRI brain with venography. There was a right temporal lobe hemorrhage with transverse sinus thrombosis. So when the patient was again reviewed in terms of history, the patient revealed that she was taking hormonal preparations for the treatment of irregular menstrual cycles. So as we see here, this patient came to the emergency with some alarm findings like papilledema, blurring of vision. So in such a situation, often we don't waste time taking all sorts of history, and often we start the patient on the diagnostic pathway, and MRI and venography is done immediately because the treatment has to be started as early as possible. So given this new onset headache in a young female, one of the first differentials that comes to my mind in the presence of papilledema is that the patient might be having a cerebral venous sinus thrombosis. So that is why this patient was immediately taken for venography and history review was done at a later point of time. So we need to sometimes tailor which has to be done first. If there is something urgent and which might change the management, that has to be done first rather than following the usual protocol, especially in the emergency settings. So this patient obviously had new onset headache with features suggestive of raised intracranial pressure. And the diagnosis, obviously, after the MR venography, it was very clear that it was a case of cerebral venous sinus thrombosis. So what helped us? In this particular patient, the patient was having blurring of vision in both eyes. There was papilledema. So these alarm findings helped us proceed with further investigations. Let us move to the next case, which is again a 25-year-old lady who presents with new onset severe headache since 6 hours. There is no vomiting. There is right temporal and right periocular pain. This patient also complained of blurring of vision, but only in one eye. The previous patient complained of blurring of vision in both eyes. This particular patient said in only one eye since the last 1 hour. The fundus was normal and the MR venography was also normal. Now, when there is unilateral headache with vision loss, always check for the intraocular pressure. So this patient was sent to the ophthalmology department emergency and they measured the intraocular pressure. It was found that in the right eye it was 60 and in the left eye it was 15, which is normal. So this patient had a diagnosis of acute anguloclausal glaucoma. This is also a vision threatening condition. And if the diagnosis is not made on time, the patient might lose vision permanently in that particular eye. And so it is very important that when this sort of presentation occurs, when there is temporal boring pain and unilateral vision loss, often the fundus might be normal. There will not be changes suggestive of glaucoma. Even in the absence of such findings, the patient might suddenly lose vision. So we should always be very careful. So these are the things that helped us clinch the diagnosis: new onset headaches in 6 hours and blurring of vision. So these red flags should always be asked, especially in the emergency department. Often patients with glaucoma are missed because today in the era of advanced neuroimaging, it is very easy to get an MRI. But if someone does not think about glaucoma, intraocular pressure measurement is not considered a standard protocol in the evaluation of a patient with headache. So we should never miss this. We should always remember to measure the intraocular pressure. It's a very simple procedure. If someone thinks of it only, they will be asking for it. So it is important to remember. So let us move to the next case. This is again a 25-year-old lady who presented with acute onset severe headache since 12 hours. The patient could not sleep at night, and the patient was sobbing and crying. When the patient came to the OPD the next morning, she could hardly keep her eyes open. She is speaking with her eyes closed. Even when you repeatedly ask the patient to open, she is not at all opening her eyes, and she is keeping on crying. The fundus was examined with great difficulty, and it was normal. So immediately the patient was asked for imaging of the brain with MRVino again because it was a young female. It was again normal. So when the history was reviewed, it was found that the patient's mother had died 2 weeks ago, and the patient was not able to cope with her work, and she was having a difficult time at work also. So disability of the patient was out of proportion to the signs that we observed. This patient was complaining of this pain and sobbing and crying, which is out of proportion to whatever physical findings that we found. And when we asked her to open the eyes, she was not at all able to, not even trying to open her eyes. So that suggested that it was something non-organic symptom, and she had somatization. So when the patient was counseled and when the patient was prescribed some antidepressants, the patient had a remarkable recovery over the next 2-3 weeks. So how do we approach and when to investigate? So this is a common problem we face. 3 billion people are suffering. So all 3 billion, do they have to undergo all sorts of investigations? Should they undergo imaging of the brain? So when there is a new onset headache, what imaging should I do? So that is the most burning question that we face. When I say imaging of the brain, MRI brain is the most appropriate investigation in a patient with new onset headache. There is limited role for doing CT head, and the most important role of a CT head is to look for a subarachnoid hemorrhage. So most of the times in the emergency department, CT head is a very easily available investigation in most of the, even the secondary and tier 2 and tier 3 cities also. It is quite easy to occur an CT scan of the head, and subarachnoid hemorrhage can reliably ruled out on a plain CT of the head. But if CT head is normal and subarachnoid hemorrhage is a strong consideration, then we proceed with lumbar puncture to look for evidence of bleed or xanthochromia. And if needed, digital subtraction angiography might also have need to be done. Coming to the next investigation, which is fundus examination. This is very, very important, and often you find papilledema or other features like hypertensive bleeds. All these findings you can find on fundus examination. Lumbar puncture and CSF manometry will help us measure the intracranial pressure. And in appropriate cases, we might have to do workup for meningitis, as we saw the previous slides, presence of fever, constitutional symptoms, presence of neurologic signs, ptosis, diplopia, presence of extraocular movement abnormality, seizures. In such a setting, we should initiate a workup for meningitis. So these are the set of investigations we saw in a patient with acute headache. In acute headache, the algorithm is completely different. We straight away go ahead with imaging. We might have to do the CSF in the emergency setting. But in patients who present with chronic headaches, over several years and months and years, the patient has been suffering from headaches. So what do I look for? These are the sort of patients in whom prudence is essential before ordering investigations. We need to do a detailed history first, followed by general examination. And general examination, what do I see? Blood pressure is something which should not be missed. If the blood pressure is very high, the patient might be having a headache, which might be because of the raised blood pressure itself. So once you control the blood pressure, the headaches might come down. 1. 2, in patients who have chronic headaches because of raised intracranial pressure, the blood pressure itself might be raised because of the Cushing's triad itself, the BP might be high in a patient who has raised intracranial pressure. The blood pressure should always be measured every patient who complains of headaches. Then we have to look for features suggestive of chronic lung disease like obesity, hypoventilation syndrome, and COPD. Because chronic CO2 retention can lead to headaches. And we might be doing all sorts of investigations, including imaging, CSF, and all other things. You might not find anything. But once you start the patient on CPAP therapy or you treat the patient with bronchodilators, these headaches will just go away. Third, we need to look for engorged neck veins. Any features to suggest superior vena cava obstruction, because superior vena cava obstruction might present with increased intracranial pressure because of the reduced venous outflow from the brain. What do we look for in ophthalmologic evaluation? Obviously, we have to examine the fundus. We should measure the intracranial pressure. We should get the evaluation of the anterior chamber of the eye to look for features of uveitis, and gonioscopy has to be done to look for the angle of the anterior chamber. Hello? Hello?
Yes, ma'am.
Am I audible? I just... Okay, all right.
Yeah,
So,
you are audible.
okay. So we should look for the temporal artery nodularity and pulsation. A neck examination has to be done. The posture of the neck has to be carefully looked at. Often we find that patients are having cervical dystonia and the neck is tilted. Once you treat the dystonia with botulinum toxin, the headache is completely gone. Likewise, we have to examine the cervical spine, thyroid, lymph nodes, look for localized masses. All these things can be easily done by a detailed physical examination. The structures of the neck, ear, nose, throat, teeth, gums, all these also have to be palpated. In fundus, I want to specifically look for papilledema because idiopathic intracranial hypertension is a very common cause of it is not common at all, but among secondary headaches, it is one of the common causes of secondary headaches. But if we don't examine the patient's fundus for papilledema, we will miss it. So definitely we have to examine the fundus. Fundus examination can also show features of hypertensive retinopathy. If there is retinal ischemia, ocular ischemic syndrome, these can be ascertained by doing a fundus examination. Then in imaging, more than CT, MRI of the brain is preferred. MR angiography may be needed in certain circumstances. CSF examination, like as I said before, manometry for opening pressure and cell, protein, sugar, and workup for chronic meningitis. A chest X-ray might be needed if the patient is having features of chronic obstructive pulmonary disease. An arterial blood gas analysis will help us look for CO2 retention. So, do we do all these investigation in each of the patient? Obviously not. So, as I said before, we need to use the magnet or the Snoop mnemonic and find out which patient will fit which investigation, and appropriate investigations have to be done so that we don't strain the system, as well as we give the diagnosis to the patient in the least number of investigations. So when imaging is done, often we find incidental findings, and this is the cause of great distress. Sometimes in the scalp, you find lipomas, osteomas, fibrous dysplasias in the scalp or in the orbits. So patients then start feeling, oh my God, I have got a small tumor. Do I get it operated? Likewise, in the paranasal sinuses, there is some mucosal thickening, some mucocele, and these findings are cause of great distress. The patient then goes to the ENT specialist and says they want some surgery, FS procedure. Often we find meningiomas, subdural hygromas, chronic subdural hematomas, arachnoid cysts, giant cisterna magna. Looking at the term giant cisterna magna, everybody's alarmed. Maybe there is some huge problem within the brain. No, these are all incidental findings, and nothing needs to be done in the majority of the cases. In these situations, even if there is an incidentally found meningioma and we operate, it is not going to lead to any improvement in the patient's symptom. Similarly, in the subarachnoid space, often there is a great alarm call. Even in today's OPD, I found a patient in whom the MRI had been reported to be having empty sella, and the patient had been referred to us for getting probably a CSF examination. But once the history was reviewed, the detailed history was taken, the patient was having history of headaches since the last 8 years, and there was absolutely no change in the frequency, severity, or the duration of the headaches. So that patient had classical migraine with aura. However, this empty sella was found as an incidental finding. Had we not taken a detailed history, and if we directly send the patient to get a lumbar puncture, it would have just added to the anxiety of the patient. needing an invasive procedure, which is lumbar puncture, which can also cause complications such as infections, and sometimes nerve root damage and local problems also can happen with lumbar puncture. And likewise, it is also going to add to the healthcare costs. So all these things have to be kept in mind. Dilated perioptic CSF phases and choroid plexus calcifications are very commonly seen, and they are non-consequential. Likewise, some arterial stenosis, incidental aneurysms might be found, cavernomas, developmental venous anomalies, and lateral sinus stenosis. These are normal or incidental findings which do not explain the patient's headaches. Likewise, sometimes you may find low-lying cerebellar tonsils. So these are not indications for getting a craniotomy or doing a foramen magnum exploration. Pineal cysts are very common. Likewise, pituitary adenomas, schwannomas, neurofibromas, epidermoid cysts, most of the times these are incidental findings and they are not the cause of the patient's headache. Parenchymal lesions like calcified granulomas might be seen. Basal ganglia mineralization and calcification is often observed in otherwise asymptomatic patients. White matter hyperintensity is because of other, like for example, the patient might have very well controlled hypertension, and you may find some non-specific white matter hyperintensities. Once someone sees white matter hyperintensities, then they report probable demyelination, multiple sclerosis might be considered. Kindly correlate clinically. This is how the MRI reports are made. This leads to a lot of distress, and of course, it is going to lead to much more. Then patients will undergo CSF. We will ask for oligoclonal bands. And the patient is in a lot of stress, and the doctor is also having limited time to talk to the patient, and it is going to open a Pandora's box. Likewise, microhemorrhages also might be found, which are otherwise non-consequential. Strokes, if found in non-eloquent areas, might need treatment for for secondary prophylaxis, but treatment of the stroke or starting secondary prophylaxis with aspirin and statin is not going to take care of the headaches. The headaches have to be treated like a primary case of primary headache only, because that is what is going to lead to symptomatic improvement in the patient. So if the physician thinks that, okay, I don't know whether the patient has a secondary cause, I will just order a MRI and the patient is going to be satisfied. It is not going to happen that way. Ordering an imaging and finding incidental findings on imaging is going to lead to more problems, and you will have to sit and talk to the patient a lot, and then you also might be forced to order more and more investigations, which is ultimately not going to help the patient. So we should always try to use our clinical acumen to find out which are the patients who will have the maximum benefit with either imaging or other forms of investigation. So to conclude, headache is very common. A systematic approach is the key. Differentiating primary from secondary headaches is the first step. Pretest probability is important to order investigations, which otherwise may be very expensive, invasive, or cumbersome. However, identifying life-threatening or vision-threatening emergencies and treating them promptly is going to be very rewarding. So for whoever residents and graduates who are attending this session, I would suggest you to maybe take a screenshot of this page, and you may read to gain more knowledge about when to evaluate, and if you find some incidental findings, how to proceed, and what are the risk factors for other. For example, you found some lesions, when you think it is MS. If you find other, maybe you got a patient in whom the imaging had already been done, and how do you counsel them? If you want to learn more about it, you can read these resources. Thank you. Hello. Hello. Hello.
जी ma'am. Hello.
Yeah. Actually.
Hello.
Yeah, I think I'm not sure whether the signal was lost, because I have completed the presentation. If anybody has any doubts, they can ask.
Hello.
Am I
Yeah,
audible?
ma'am. Yeah, you are very much audible, ma'am.
Okay.
Ma'am, like there are two queries as of now, which I can see, ma'am. One
Okay.
is what is the science behind alternating hemispheric headache appearing during sleep, maybe REM sleep? And second, could you throw more light on hypnic headaches?
Okay.
Yes,
So the first question is headaches during sleep.
yes, ma'am.
So when the patient has nocturnal awakenings due to headache, it is always a red flag. Alternating hemicranial headache can happen as a primary headache disorder also. So when the two questions that you have asked are actually interrelated. Hypnic headaches are those headaches in which the patient goes to sleep and then awakens, and later on when evaluating you find that the patient has some sort of carbon dioxide retention due to either a sleep apnea or due to some underlying pulmonary disease, that the patient develops carbon dioxide retention during sleep, because during sleep actually the uh, when there is associated sleep related breathing disorder, the patient tends to retain carbon dioxide. So that can be one reason for development of hypnic headaches. One. Two, many a times we find that even hypnic headaches can be a primary headache disorder. You have such a patient, but you are not able to find any particular etiology. So often it is because of some hemodynamic changes that happen during sleep and associated respiratory changes. So if you're not able to find any other secondary disease and still the patient has nocturnal awakenings, it is probably related to the neurotransmitter release and the activation of the trigeminal system. The exact pathogenesis is unknown, but however, it is postulated that due to the sympathetic surge and the dysfunction of the autonomic nervous system because of dysfunction of the neurotransmitters, there could be dilatation of the trigeminal vascular system, and that could be presenting in the patient as nocturnal hemicranial headaches.
Right. Right, ma'am. Ma'am, there is another comment from Dr. M.R. Jain that is visible to me, ma'am, that refractive error must be considered in all the cases of headache that they have written, sir. Written, ma'am.
Right. Yes, I would agree with that. Refractive error is a very common uh, cause of blindness as well as headaches. But recent research shows that even in people, even in children or adults who have refractive error, there is an associated primary headache disorder, and just correcting the refractive error might not lead to complete resolution of the headaches in such patients. So, of course, we should correct the refractive error. But even after correcting the refractive error, if the headache is not completely gone, then you might have to consider treatment for primary headache disorders.
Right, ma'am. Right, ma'am. Ma'am, thank you very much. Like I also had some network issues because the voice was being that was breaking in between in the end, ma'am. So
Oh,
like, ma'am, saw your presentation. That was really very good, ma'am. I would like to appreciate that, like the way you presented the smart ways to approach a patient of headache in the beginning, and then with the case vignettes and ma'am, the all the investigation and treatment, ma'am. Very like precisely that you presented, ma'am. Thank you, ma'am, for such a wonderful presentation.
thank you.
And yeah, ma'am. I think if any other participants they have any of their doubts or queries or remarks, they can type in the chat box. Or if like anyone can raise their hand, we can unmute them and they can ask it verbally. I think, ma'am, they understood understood the topic very well. So good, ma'am.
Thank you. Thank you so
Okay.
much.
So, ma'am, like continuing the tradition, I would like to invite Professor Ajay Kumar Sood, Deputy Secretary, National Academy of Medical Sciences, for the vote of thanks.
Thank you, Dr. Jaswant. On behalf of the National Academy of Medical Sciences, we are really grateful to the distinguished speaker for this evening, Dr. Ila Varsi, for covering this topic of how to approach a patient with headache. Although it is a very common symptom, but the way you have explained, I think our participants, especially the students, they have greatly benefited. So we are really grateful to you for your time, and we look forward for your support in future also. Thank you so much. I will also place on record the support which we have got from the head of Department of Neurology, All India Institute of Medical Sciences, Professor Padma Srivastava. She has been the chief coordinator for this series on neurology, and she has identified the topics as well as the speaker. So we are really grateful to Madam for helping us in organizing this series. I will also like to thank the participants who are present in this particular session. Especially, I noted our senior fellow, Professor Ten, who was there. So thank you so much, sir, for your presence, and your presence is a source of encouragement for all of us. Now, for the participant, again, I want to, especially to the PG students, I want to make an appeal that with this session, we are completing this series on neurology. And very soon, we are going to have another series on orthopedics, another one on applied physiology for clinical resident. So that will soon announce, and we'll put the details on our website. In addition, I also want to inform all the residents, especially PG students, that in collaboration with All India Institute of Medical Sciences, New Delhi, we are starting from 1st of September, that is Friday, that is first Friday of every month onward, we are going to have a joint CME program with AIMS. So nearly 16 AIMS who have postgraduate program, they are joining us. And I also invite other students from other medical colleges to join us. The details are on the website, and the topics are going to be to begin with the common interest topics. For example, it could be now artificial intelligence is quite important these days. So what is the role of artificial intelligence in health, engineering in medical, then patient safety protocols, then hospital acquired infection, like soft skills for the care provider. So like that, we have identified 8 themes which are common all across the specialties. So we are requesting all of us, all of the participants and all the students as well as the faculty members who are present in this particular session to disseminate this information so that the students can register. It is free of cost registration online. We have also communicated to all the medical colleges as well as all the AIMS and requesting their directors and deans to circulate this. So with these words, I would like to thank all the participants and special thanks to Dr. Jaswant, who has been helping us throughout. We started the program in January and he has been associated with us for helping us in moderating and working for us. Thank you so much, Dr. Jaswant. In the last, I would like to place on record the support from our IT unit, Mr. Ravi and Mr. Anil, who have been working in the background, writing to the students details about the program, the Zoom link, and so on and so forth. So with these words, once again, I would like to thank all who have been with us this evening for making this evening very interesting. So with these words, I thank and hand over to Dr. Jaswant.
So thank you very much, sir. Thank you very much. And thank you very much for providing me the opportunity to be the part of this CME. And sir, you rightly said that the neurology series has been concluded with an excellent presentation. So I think with this note, we can close this session. So thank you, sir.
Thank you.